through some of the important informations and slides. This is the part 2 of the continuing webinar. See, cervical disorders are very common, and the international figures indicate that at any point of time, nearly 10 to 15% of the population will be suffering an episode of neck pain. Neck pain, as I said, that very frequently the physiotherapist has to see the patients with neck pain. And earlier in the previous part, in the first part, I just explained to you about the palpatory landmarks, and I already demonstrated on the skeleton, and that will be soon will be available for the reference in the YouTube. And this poor body posture as well as poor design of the workstation. See, we may find sometimes, and this slide you can see here, there is one, this is called as bifocal posture. The head has excessively translated anteriorly, and this is creating some, you can see the cursor moving there, or I can just show with my fingers here. And this is the bifocal posture, where there is excessive anterior translation of the head and leading to increased lordosis in the cervical region, and that may lead to the suboccipital tightness, and the suboccipital tightness can often lead to the trigger points, and it can cause the headaches. And the headaches due to the cervical involvement are called as the cervicogenic headaches. And why it is important is, we may treat and we may send back the person, but then again the person may be coming back and tell that there is an experience of another episode of neck pain. So along with our treatment, we need to correct the workplace also, that is the ergonomics part. We may ask the person to take some pictures of the place of work, and then subsequently we may make necessary corrections over there. So alarmingly, 30 to 50% of the general population suffer from neck pain annually, and with prevalence of 15% in the males and 23% in the females. And these are the references for the, as we are in the evidence-based practice era. So that's why I'm just discussing about this component. This is the bifocal posture. And as I mentioned about the cervicogenic headaches, it's one unilateral headache, and there is a difference between cervicogenic headache and the migraine. Cervicogenic headache is often unilateral, and migraine can be at any part of the head that can appear. But specifically for cervicogenic headaches, we will have involvement at the cervical spine, and often due to the trigger point, if we palpate, then the headaches will be experienced. Presentations of the cervicogenic headache, and this is due to the trigger points. We often get the cervicogenic headaches, and just I will show you some practicals of how exactly we are identifying for the trigger points. So you can see here that especially see for the sternocleidomastoid, if there is a trigger point in the sternocleidomastoid, and often we are palpating with this is called as pincer palpation. We are using the pincer palpation to identify the trigger point. And why it is called as pincer mechanism? Because if you see the just a scorpion, if you just think about the scorpion, and then the grasp of the scorpion, similarly you palpate for the trigger points, and then if there is a trigger point in the sternocleidomastoid, there will be often frontal headache is experienced. So that is a classical case of cervicogenic headache. And the headaches also can be due to the involvement of the facet joints. That also, if facet is affected, sometimes there can be trigger points. Similarly, the suboccipital muscles. The suboccipital muscles are attaching from the occiput to the C2, and that is basically, if we are doing this action, just if you put your hand below the occiput and then you poke the chin out, then you can feel the movement or contraction of the suboccipital muscles, and that muscle becomes tight. And if the suboccipital muscle is becoming tight, the suboccipital muscle is having attachment. Some component of the suboccipital muscle has the attachment to the dura mater. And when the dura mater is getting pulled, and specifically when we are talking about suboccipital muscles, we have obliquus capitis superior, which is oriented this way, obliquus capitis superior, then obliquus capitis inferior, it's oriented this way, and rectus capitis posterior major and rectus capitis posterior minor. So out of this, the rectus capitis posterior minor, if any of you are interested in doing the research work, then that's what you can. A lot of work is going on about the suboccipital muscles and its attachment to the dura mater. And what happens is when the dura is getting pulled, obviously it is going to restrict the blood flow, and that can cause exertional headaches. So that is one very important thing what we need to see. That's the suboccipital muscles and the head translations. And subsequently, in the first part, I already told you about the palpation. Just I wanted to tell you about the trigger points. And if we have got the trigger, the levator scapula, you see the levator scapula is attaching from C1 to C4 region to the superior angle of the scapula, levator scapula. So if there is a trigger point in levator scapula, the pain will be experienced here. And in case of trapezius, the upper traps, we have the junction of upper 2/3 and lower 1/3, where upper traps we will have trigger point here in this area. So trapezius also, if there is a trigger point, there can be occipital headache. Sternocleidomastoid, there is a trigger point, there can be frontal headache. So that's about the cervicogenic headaches. And I'll be again continuing with that. I was talking about the trigger points, then I will do the practicals about the trigger points, how to palpate. The trigger points is very highly sensitive because we have so many C fibers taking origin from that particular point. Then I also showed you the pincer palpation, and that's what I just showed how to palpate. And again you can just see here the pincer palpation. I am doing the palpation for the upper traps, and if there is a trigger point, then jump sign is there. Due to that intense pain, the person will slightly jump. That is called a jump sign. And this is the upper cross syndrome, which again, along with the cervical spine, we may have to work with the thoracic spine. And then today I am primarily discussing about the cervical spine. And upper cross syndrome, the term was coined by Vladimir Yanda. And every time we have to see the importance of the passive component. I showed the mobilization techniques in the part 1 of the video, which already updated in the YouTube before I took this particular presentation. And then this is the muscular component, and this is the neural component. We have to work on the 3 components: passive component, active component, and the neural component. And this is about the attachment of I was talking about the suboccipitals and attachment to the dura. I am taking it a little close by, and you can see that attachment of the rectus capitis posterior minor to the dura mater. And this is the joint, the C1 joint and the C1 C2 joint. C1 is convex and concave, and C1 C2 is the convex joint. And this is something very important we need to check for the cervical spine. This is the vertebral artery. So if VBI is there, this is the facet joint. So when we mobilize, and especially sometimes there can be displacement of these articular meniscoids. There can be displacement, and with mobilization we can put it back into the joint position, original optimum structural and functional position. This is another very nice slide. You can see the articular or the synovial fold, it is distributing the load in the facet, and sometimes due to inappropriate positioning it can get displaced, and with mobilization we can put it back into its original structural and functional position. And this is about the facet joints, and it is making one angulations, and facet joints can be the cause of pain, and there are so many publications related to it. And this is the C1 C2 region, and just this is something very commonly we will come across if somebody is having a crease in case of cervical spine involvement. And if there is a crease, this is the area of hypermobility. Above and below there is a tendency of hypermobility or stiffness. And so this is the observatory part. And then when there is a hypermobility or stiffness, that time you need to mobilize it and correct it. And this is again one of the lateral view where there is increased lordosis. And in this kind of presentations, do remember when there is area of a prominent line or crease is there, above and below there is hypermobility or stiffness, you need to mobilize it to restore back the normal joint play, so that the joint becomes normal and normal arthrokinematic reflex is restored. And this is the examinations part. I'll be just showing the lower cervical spine examination also. I just finished the upper cervical spine examinations. And this is the PPI VMs I was just talking before. The PPI VMs where I'm placing the mid finger in the interspinal space, index ring finger on the facet, and then I'm taking it for flexion, extension, side flexions, and then rotation. Right. So normally with flexion we can feel the joint opens up. With the extension the joint approximates in the PPI VMs. But if we are not able to feel, that means the joint is affected. Then coming to the lateral PA glides. The lateral PA glides, you see I already showed on the skeleton that we are palpating on the lateral PA joint, and then we are giving the lateral PA glide. And this is the VBI testing. We are taking for the neck for extension, and basically we have to. And if you are doing one test, there are so many, around 12 tests are there, and if you are doing one test, then it should be extension and rotation. We should do that test. So this is the position where the vertebral artery gets maximally compromised. Rotation, and then we can take it for extension. And minimum duration we can keep it for 10 seconds and maximum for 40 seconds we have to place. And for if you want to examine directly what exactly is happening, then you can go for the transcranial Doppler and to see the extent of vertebrobacillary insufficiency. We have done some studies, me and one of our colleagues. So you can see that this is how we can measure the transcranial Doppler, the extent of compromise of the vertebral artery. And you can see we can measure the systolic velocity, diastolic velocity, mean systolic velocity, diastolic velocity with and if there is a VBI component, then we will have the velocity will be shooting up. And this is something very useful technique. What are the important useful techniques? The cervical epiglides. You see, I have supported the occiput, and from the mental tuberosity, I am applying the glide anterior to posterior. It's a very useful and very safe technique to apply for the cervical spine, cervical epiglides. And this is I was talking about the suboccipital muscles. And yes, obviously we may have the involvement of the, as I said, we may have the involvement of the facets, we may have involvement due to the muscles, we may have involvement due to the nerves also, because in case of disc bulge, sometimes there can be compression to the dura, to the nerve, and we may get the symptoms due to the neural issues also. And that's what this is the component obliquus capitis superior, obliquus capitis inferior, rectus capitis posterior major, and rectus capitis posterior minor muscles. And in that case, we can go for the suboccipital's muscle energy technique, and where I am supporting the C2, and then I'll be demonstrating that in the practicals. And we can go for the cranial base release technique. This is also very useful technique for the treatment of cervicogenic headaches and for the upper cervical spine involvement. You see, I place the hand below the occiput, and then I am applying the force posterior and superior, and maintaining it. So obviously this is going to open up the CO, C1 and C2, C1, C2 joints, and also it is going to lengthen the suboccipital muscle. We can go for the facet manipulations. You just see here. So specific manipulations, mobilizations, already I showed on the skeleton, and some techniques I showed here also. This is the manipulation. This is the upslope manipulation. On the facet, identify the affected facet, and then I'm manipulating it. That was the upslope manipulation. And we can also give the manipulation in the sitting position. You see, mid finger I have placed it on the facet, and head is rotated to opposite side, side flex, extended, go to the barrier and give a thrust to the opposite side eyeball. And you can hear that sound. That is called as the cavitations. And this is the MET for pectoralis major muscle. And we can apply for various components, the sternal components and the clavicular components. And there is a question I can see, sir, a patient having neck pain during forward flexion and during cervical rotation also, so that we can do a physiotherapist, what we can advise to that. That's what, if somebody is having a forward neck flexion, that I just showed, that you can go for that epiglide, and you can just give the epiglide, cervical epiglides. That is very useful. And then some other exercises I'll be just covering up. See, if there is pectoralis major tightness, you can go for the muscle energy techniques. Pectoralis minor also sometimes will be getting involved, because that also will contribute to the cervical spine dynamics. So you need to work on the pectoralis minor also if there is upper cross syndromes. And this is the trapezius, and trapezius trigger point. And you see, you can give the MET for the upper traps. And this is the sternocleidomastoid. I already explained on the model sternocleidomastoid, there can be the trigger point referral pattern, and you can give the MET for the sternocleidomastoid muscle. And this is the levator scapula orientation, and I already differentiated. In case of levator scapula involvement, you see with the superior angle of the scapula, you will be getting the trigger points. This is the area of the trigger points. And yes, so what I will do is I will be showing you some of the practicals now, and just okay. Yes, just lie down on your abdomen. Okay. No. You just remove the specs and lie down like this. Show me the skeleton in the meantime. I'll just describe the skeleton. Lie down on your abdomen. Head this side, head this side, head this side. Okay, so coming to the lower cervical spine. So how to palpate for the lower cervical spine? The vertebra prominence is C7, and the C6 is the, when you are going for extension, you ask the person for extension, the first vertebra which will move anterior is C6, and you palpate for the C5, C4. From the spinous process, if you palpate 1 inch lateral and about 2 millimeter down, you can palpate for the facet joints. So I'll be showing you the mobilization things. Already I demonstrated. Just do the chin tuck, put your forehead on the palm. Hand crossed, hand cross like this. Yes, tuck the chin in. Okay, now you see, you can go for the central PA glide in the midline. See the grades we have to apply. This is the central PA glide. Lateral PA glide from the posterior arch of atlas, about 1 inch lateral and 2 millimeter down, that is the C1, C2. You can give the glides with the grades, grade 1, 2, 3, 4. So similarly from C3, just take it in. Yes, from C3, C2 is there, C3, 1 inch lateral and 2 millimeter down, you palpate for the facet, and you can give the glide, the lateral PA glide. So the lateral PA glide, if you have got the facet involvement, then you give the lateral PA glide to correct it. And you have got the transverse glides, you palpate from the spinous process, lateral to the spinous process, and give the glide in the transverse plane. And then come to on your back, just come up. Okay, so we can go for the epiglides, anterior to posterior glide. Already I showed you that this is very effective technique. And then I'll just show you that for the VBI testing, which is very important, you take the neck for extension and rotation. If VBI test is positive, we will get dizziness, diplopia, dysarthria, dysphagia, drop attacks. VBI is present, then you should not apply any manipulations, especially the thrust technique. But you can apply the mobilizations, absolutely no problem. And I'll show you some, suppose you have got involvement of the left side C2, C3 facet. You can go for the rotation, side flexion, extension, and this is one down slope manipulation I am showing. Then you can give the thrust. One small thrust you have to apply. Similarly, we can give the thrust techniques in the sitting position also. In subject in sitting position, we can give the thrust technique. Say I want to manipulate the thrust technique for the left side, then rotation to the right side, extension, then you have to give the thrust directed to the opposite side eyeball. And similarly, you can apply the technique. Suppose there is a lot of irritation in the upper traps. Lot of irritation in the upper traps is there. So you can go for the PRT technique, positional release technique. So upper traps you palpate for the submaximal threshold, and then you take the neck for extension, side flexion to the same side and rotation to opposite side, and then maintain it for about 90 seconds. And similarly, suppose there is a moderate tightness is there and the pain threshold in the vast scale pain has reduced substantially. In that case, you can give the MFR technique. You can give the MFR. You see how I am giving the MFR. So for MFR, I am taking the neck for flexion, side flexion and rotation to the same side. So this is the site of involvement about 2 inches above. I will be using my knuckles I can use, or I can use the hypothenar contact. And in case of fibrosis, there is increased enhancement of TNF alpha factor or TGB beta factor. So when you give the longitudinal stresses, that tightness will be getting corrected, normal dynamics of the muscles will be getting restored. And for the muscle energy technique, for say for example the traps, you can go for the flexion, side flexion to opposite side and rotation to same side. You go for the barrier, ask the person to lift the shoulder upwards, lift it up. Yes, this movement has to be restricted. Give it gentle force, 1 2 3 4 5 6, fine, relax. Okay, lift it up, 1 2 3 4 5 6, fine, relax. Okay, so these are some of the important maneuvers and techniques what we will come across and what we will be using. I can see one question. Sir, a patient having a pain during rotation and he can't holding a neck in morning wake-up time. Okay, so in that case what you can do is you have to identify which particular facet is affected or which particular muscle is affected. Then mostly, as we were talking, it could be due to the facet involvement, and we can mobilize to relocate or restore the normal arthrokinematics to correct the problem. And I can see another question that in high BP condition, can we apply for glide? That is by Tannu Dhingra. I can see one question in high BP conditions. Yes, we can go for the mobilization techniques, but we should not apply the high velocity thrust technique. That is what I can advise you. And if the BP is too high, then we may ask the person to consult the family consultant or this thing. But as far as the manual therapy is concerned, mobilization technique can be applied very safely. Absolutely, there is no problem. So I think these are the. There is one question by again Tannu Dhingra in neural component also, that if patient feels this thing, can we go for the this question just yes. So yes, as I told that neural component, if you are there, then you can go for the neural mobilizations if it is required. And we have to see that in case of facet also, the neural is going to, a nerve is going to get affected. In case of disc prolapse also, the nerve is going to get affected. So we have to see if the facet is the cause, we have to go for the facet mobilizations to correct it. We have got the issues with the disc. Something important about the disc, I'll just cover now. I'll put some more slides before I just end the presentations. And this is about the layering palpation, and which I have developed the grading systems for the soft tissues, which there is no proper grading systems for the soft tissues. And you can see here we have the various layers of the fascias. I am talking about the fascial and some of the people who are interested in research work. So there is no gradation of fascial dysfunction, so I have done the gradations, and there are layer 1, layer 2, layer 3, layer 4. That's why we find the fascias, and this according to my grading system, which is published in my book This is the manual therapy of the pelvic complex, and I have written another book, the clinical symposia in manual therapy. Both the books are available in Flipkart and in Amazon, and also it is available through our Manual Therapy Foundation of India website. You can visit www.mtfi.net. And somebody was asking me about VBI test, that already I have covered. You can see in the previous video. Sir, in cervical spondylosis, which glides will be more effective? See, the transverse glides will be quite effective. Lateral glides will be quite effective. You can examine and you can apply the technique. And usually for cervical spine from MTFI, we conduct near to 2 days of workshops. And if any of you will be interested in future, you can join our future workshops. And this is the best we can give the information through the webinar, some of the preliminary informations. And if you are not very highly skilled enough, I'll tell you not to apply these thrust techniques. There can be little bit of whether with small mobilizations and all you can apply. These are the grade 1s according to my gradings. Adherence of layer 1, 2, 3, 4. Grade 2, adherence of layers 2, 3 and 4. Grade 3, adherence of layer 3 and 4. Grade 4, toughness in deep fascia. And grade 5 is normal. This is my book, and I showed you already. And I wanted to tell you about the whether it is facet involvement or disc involvement. You will have muscular issues. In that case, you can use the pressure biofeedback unit to correct. This is how we can use the pressure biofeedback unit to strengthen the deep neck flexors. So, and I have undergone the specific training under Professor Gondlin Joule, who was the founder, and along with Fala, and they have done a lot of publications. So along with that, neck pain, the deep neck flexors will become weak, and then you can go for this pressure biofeedback unit. In case you don't have the feedback unit, you can ask the person. Best is the pressure biofeedback unit. If you don't, what you will do? Ask the person to do the chin tuck exercises. Chin tuck exercises. That is going to activate the deep neck flexors. You can palpate your ventral part of the neck, and then you just tuck the chin in. You can feel there is activation of the deep neck flexors muscle. And along with that, you can ask also make the person to make the fist and then slightly press it to activate further the deep neck flexor muscles. So next, the best one, as I told you, is the pressure biofeedback unit. This is a craniocervical flexion test. There are so many methods. I have taken 2 days of workshop. I have been trained under this how to activate using the pressure biofeedback unit. And along with that, cervical spine involvement, you can go also for this thoracic spine manipulation, where you can palpate for the transverse processes, and then you can apply the thrust over there. So this is the crossed hand manipulation, and it is very useful technique, but you should be skilled enough to apply it very effectively. I have this video in YouTube also, and maybe what you can do is you can subscribe for the channel, so that new updates, new research publications you can apply, or you will be getting the notifications if you are interested only. Otherwise, it's okay. So you can manipulate the thoracic region. So, and scapular stability, along with that we can go for the scapular stability exercises along with the deep neck flexor. How manual therapy helps? Restoring the joint play, number 1. Restorations of the arthrokinematic reflex. And this is the neck trap model. Change in the pain threshold, triggering the reflex activity due to manipulation. Physiological changes following the manipulations. Central pain mechanisms, which is a lot of work is going on this aspect. And multimodal approach, as per the evidence-based practice, are the best. Along with the mobilizations, you can go for the exercise programs. And these are the 2 books. And before I finish, let me just take you through one of my book on clinical symposia about the cervicogenic headaches. So this is about the cervicogenic headache, what I explained. And cervicogenic headaches are due to, as I told you, that due to the trigger points. In my book, I have described about what is the difference between migraine and cervicogenic headaches. You know, another important thing, cervicogenic headache is often unilateral, and whereas migraine can be like a tsunami, can due to non-specific causes. And predisposing factors I have explained. You know, inappropriate positions, we go for the subjective examinations, palpations, overpressures, I have already explained. In the previous, there are 2 videos in the YouTube, you can see that. The cranial base release technique I just explained earlier. Cervical epiglide techniques are very useful. Lateral PA glide techniques. Then transverse glide techniques are very useful techniques. Then you can go for the high velocity thrust techniques and suboccipitals, MET for the suboccipitals. And there is another one, and somebody has asked sir, contraindication for glides. That also I'll just tell you. Upper cross syndrome. This is just so many things I have discussed in the today's webinar, and maybe if you have missed certain things, you can, it is already there in the YouTube store. You can see them, and so many other videos are also there. And if you will be in the future, will be interested to attend for better clarity understanding under supervision, then you can join for our workshops and certificate courses. And this is how the deep neck flexors, I told you that pressure biofeedback unit we are using to activate the deep neck flexors. And this is the METs you can apply for the pectoralis major and pectoralis minor tightness identification. You can do MET for the trapezius, MET for the levator scapula. I already explained from C1 to C4 to superior angle of the scantation, the scapular stability training. You can go for the scapular tapping techniques. Then I already showed you on the slide about deep neck flexor strengthening using the pressure biofeedback unit. And these are some of the exercises you can ask for the chin tuck, the epiglides of the cervical spine, and the epiglide for the humeral head. If you have got issues, this is about upper cross syndrome. Then upon in case of cervical spine involvement, you will have thoracic involvement. You can go for thoracic mobilizations. You can use a physio ball to restore the joint play of the thoracic region. So this is the book Clinical Symposia in Manual Therapy, and Manual Therapy Foundation is ISO 9001-2000 certified, and we are having the accreditation to United Accreditation Foundation, that is at United States of America, and we are having a collaboration with JOSPET. We are the first organization from India to have the collaboration with the Journal of Orthopedic and Sports Physiotherapy, JOSPT, one of the best cited journals. And this is, you can note down my email ID and website, professor.mohanty@gmail.com, and website www.mtfi.net. You can see a lot of resources available out there. And so thank you very much for joining in this webinars. And there is a question by Sal Grover. What are the contraindications for the glides? Well, the contraindications for the manual therapy is very important. That is, you can go for, I mean, first of all, let me tell you when to apply and when not to apply. When to apply is that when you have got mechanical problems, you see facetal involvement is there, that time you go for the joint mobilizations. When not to apply, in fracture displacements, in cancer, in infective arthritis, infective conditions. In those conditions, you should not apply the manipulations. So thank you very much, and if you have got any queries, you can just send the email to me. And thank you for joining. And maybe we'll be planning some more webinars. And if you have got any queries, you can write here also, and I can reply in YouTube, and or you can send the email. So thank you, Umakan. Thank you, Nilofar, for your comments. Thank you, Baswati Dev, Physio Medic, and all other people who have joined me today. And I can see that if there is a severe pain, what are the options? Gudda Sharma's question. Severe pain is there. Then what you can do is you can go for the PRT, positional release techniques, or we have got we are physiotherapists. We have got electrotherapeutic modalities also. You can use them also. But for specific mechanical problems, specific mechanical treatments are always very useful. And thank you very much. I'm getting a lot of good responses for so many people who have joined me. And once again, stay safe at home at this time, and be very alert, because we are in a critical juncture in the world due to COVID-19. And again, wish you all the best, and thank you all for joining me in this webinar.